The topic of today's discussion is cyst classification, mainly of the orofacial region. We will be using the 5th edition of the World Health Organization classification of head and neck tumors, which is the latest classification published by the organization in 2022. For starters, let us discuss the definition of a cyst. It is a fluid-filled cavity lined by epithelium and surrounded by a capsule, usually of fibrous tissue. These cysts can be true cysts, lined by epithelium, or pseudocysts with no epithelial lining. Cysts of the orofacial region are divided into 3 categories: cysts of the jaws, cysts associated with the maxillary antrum, and cysts of the soft tissues of the mouth, face, neck, and salivary glands. It is important to note that in the latest classification, cysts are classified under the term cyst of the jaw with no subdivisions. This is different compared to the 2017 classification, which defined 2 subdivisions: odontogenic cysts of inflammatory origin and odontogenic/non-odontogenic developmental cysts. Most cysts of the jaw are odontogenic, meaning they arise from tooth-forming tissues. We will be discussing the cysts of the jaws based on the latest classification. Age, gender, localization preferences, and essential diagnostic criteria of jaw cysts are the main factors influencing the classification of these cysts. Radicular cyst. Slightly more prevalent in males between the ages of 40–60, it is found in the periapical area of non-vital teeth. It is lined by non-keratinized, stratified squamous epithelium. Another manifestation of this cyst is the residual cyst, which is essentially the same without the offending dentition. They are most commonly found in the anterior region of the maxilla. Inflammatory collateral cysts predominantly affects males and associated with partially or recently erupted vital teeth. The lamina dura is still intact, and the radiolucency seen in radiographs is distinct. They are categorized into 2 types of cysts: paradental cyst and mandibular buccal bifurcation cyst, or MBBC, for short paradental cysts, are prevalent in patients in their 40s and mainly affect mandibular third molars, while MBBC is more prevalent in teens and young adults and affects the buccal aspect of the mandibular first or second molars. Another example of a cyst that has a distinct, well-defined radiolucency is the dentigerous cyst. Occurring in the 2nd and 3rd decades of life with a higher male prevalence, it is associated with crowns of unerupted teeth, most commonly third molars. The cyst is attached to the cemento-enamel junction and is lined with non-keratinized, stratified squamous epithelium with no palisaded basal cells. Next, we have gingival cysts, which can also be separated into 2 types: adult and infant types. It affects both males and females equally. The adult type is classified by thin epithelial lining and appears in the attached gingiva area of the mandibular premolar to canine region, affecting patients in their 50s or 60s. The infant type occurs in the first 3 months of life, anywhere on the edentulous alveolar ridge. A cyst that is commonly found in the same area of the mandible as the gingival cyst is the lateral periodontal cyst. With a higher male prevalence, mainly affecting the elderly, it is characterized by whorled epithelial plaques, and it's present on the lateral aspect or between the roots of vital erupted teeth. If there is multilocularity, it is referred to as botryoid odontogenic cyst. A cyst associated with epithelial lining with orthokeratinization in tooth-bearing areas of the jaw is the orthokeratinized odontogenic cyst. With a higher prevalence in males and occurring in late adulthood, it is mostly found in the ramus region of the mandible. Another cyst, predominantly found in that region of the mandible, is the odontogenic keratocyst. Parakeratinized lining and palisaded hyperchromatic basal cells are essential for diagnosing this cyst. A type of cyst affecting the anterior aspect of the mandible is the glandular odontogenic cyst, diagnosed by the presence of a radiolucent cyst lesion associated with tooth-bearing areas of the jaw and epithelial lining of variable thickness. A cyst found almost equally in both jaws and with no gender predilection is the calcifying odontogenic cyst. Diagnosed by its cystic architecture and distinct ghost cells, it affects patients in young adulthood. Moving back to the maxilla, we have a couple of cysts left to discuss. The nasopalatine duct cyst occurs in the midline of the anterior hard palate. The size of the cyst should be more than 6 mm to avoid misdiagnosis, and it should have a non-keratinized squamous or respiratory epithelium lining. Finally, a less common cyst that manifests in the posterior aspect of the maxilla is the surgical ciliated cyst. As the name suggests, it is associated with a history of previous surgery. The radiograph shows a well-demarcated radiolucent cyst, and histologically, it is lined by respiratory epithelium. These jaw cysts were the main ones discussed by the World Health Organization, and this updated classification for jaw cysts is a step forward in oral health care. With greater clarity and finer distinctions, it allows us to diagnose cysts with greater precision. The journey of jaw cyst classification continues with promising advancements in the upcoming years. These advancements will pave the path for more accurate diagnosis and effective treatment, becoming the standard for patients, improving oral health for all. Thank you for listening.